Hi, this is Wilkins, Chapter 22, Dental Stains and Discolorations. So we've got our learning objectives that we're going to be able to recognize and identify certain types of stains, be able to differentiate between stains, and what do we need to tell the patient about what we're doing and why they have stains, and also to determine the appropriate clinical approaches for removing the stain as well as tooth whitening. So let's get right into it. What is the significance of stain? The significance of stains is primarily the appearance or cosmetic effect. Excuse me. So in general, any detrimental effect on the teeth or gingival tissue is related to the biofilm or the calculus that the stain occurs in. So thick deposits of stain conceivably can provide a rough surface on which dental biofilm can collect and irritate the adjacent tissue. And certain stains provide a means for evaluating oral cleanliness and the patient's habits of personal care. So review the keywords on box 22-1 for your terminology. So let's talk about the classification of stains. You can have intrinsic or extrinsic stain. Now, extrinsic stains occur on the external surface of the tooth and may be removed by procedures such as toothbrushing, scaling, and polishing. Versus intrinsic stains occur within the tooth surface and cannot be removed by techniques of scaling or polishing. Intrinsic stains, though, may be improved by certain whitening procedures. We also classify the source of the stain: exogenous, endogenous. Okay, so exogenous stain develop or originate from sources outside the tooth. Exogenous stains may be extrinsic or stay on the outer surface of the tooth, or intrinsic and become incorporated within the tooth. Endogenous stains develop or originate within the tooth. Endogenous stains are always intrinsic and usually are discolorations of the dentin reflected through the enamel. We need to be able to recognize and identify the different types of stains. So more than one type of stain can occur, and more than one etiological factor may cause the stains or discolorations of an individual's dentition. So a differential diagnosis may be needed in order to plan whether an appropriate intervention is indicated. And we always start with the medical dental history. The developmental complications, medications, tobacco use, and fluoride histories all contribute necessary information. So accurately prepared medical, dental, and social histories, as well as ethnic practices, can provide information to supplement clinical observations. We also want to talk about food. We need to assess the patient's food diary that may aid in identifying certain contributory factors, as well as their oral hygiene habits. The history of personal biofilm removal with the type and frequency of use of the toothbrush. Is an electronic toothbrush, or is it a manual toothbrush? Soft, medium, and hard bristles? Are they flossing or using other supplemental materials or devices? May help explain the presence or absence of certain stains. So the state of the oral hygiene for your individual patient and oral cleanliness is a significance in the occurrence of dental stains. So stains can occur directly on the tooth surface itself. Stains are usually directly associated with biofilm or pellicle on the surface of the enamel, or exposed toothbrushing by the patient. Certain stains can be removed by scaling, whereas others require scaling and polishing. We're going to get into that in chapter 45. When stains are tenacious, excessive polishing needs to be avoided. And that's our first go-to, is wanting to use a coarse prophy paste and polish it off. We're not doing that. As mild and abrasive agent needs to be used as possible, and precautions need to be taken to prevent the abrasion of the tooth surface or the gingival margin. Every time you polish, you're removing a layer of fluoride-rich tooth surface, and you don't want to overheat the tooth with the power-driven polisher. So you have stains that are on the surface. You can also have stains that are incorporated within tooth deposits. And when stain is included within the substance of a soft deposit or calculus, it's removed with the deposit. Then you also have stains that are incorporated within the tooth. And when a stain is intrinsic, whether exogenous or endogenous, it can't be removed by scaling or polishing. So you need to evaluate the patient for possible whitening procedures if the patient is concerned about the color of their teeth. So let's go into the different extrinsic stains. And yes, you need to know these. The most frequently observed stains are yellow, green, black line, tobacco, and tobacco stains, brown stains, orange and red stains, and metallic stains. So the first four are going to be described first because they're more common. So let's talk a little bit about yellow stain. The clinical features, it's dull, yellowish discoloration of dental biofilm. And you have a picture of that in figure 22.1. The distribution of the tooth surface yellow stain can be generalized or localized, and it is common in all ages. More evident is when personal oral care procedures are neglected. That's when you're going to see it. And the stain for yellow stain is usually dietary sources. So this is a picture of yellow stain. You can see it just sort of circling around the gingival margin. Now, green stain, for the clinical features, it's light or yellowish green to very dark green. And this, again, is embedded in dental biofilm. It occurs in three general forms: is a small curved line following the contour of the facial gingival margin, or smeared irregularly that may occur over the entire facial surface, or it can be streaked following grooves or lines in the enamel. The stain is frequently superimposed by soft yellow or gray stains, which are more materia alba and food debris. But dark green stains may become embedded in the surface enamel and be observed as exogenous intrinsic stain when the superficial layers of the deposit are removed. Enamel understain is sometimes demineralized as a result of karyogenic biofilm. So the rough demineralized surface also encourages biofilm retention, more demineralization, and recurrence of the green stain. For the distribution of green stain, it's primarily on the facial and often extends to the proximal surfaces. It's most frequently found on the facial gingival third of the maxillary anterior teeth. Now, what is it composed of? Chromogenic bacteria and fungi. There's also decomposed hemoglobin. Inorganic elements include calcium, potassium, sodium, silicon, magnesium, phosphorus, and other elements in small amounts. And this can occur at any age, primarily found in childhood, and it collects both on permanent and primary dentition. The recurrence depends on the personal oral care that the patient's doing. Etiology: green stains result from oral uncleanliness, chromogenic bacteria, and that gingival hemorrhage, all right? That's that decomposed hemoglobin. Chromogenic bacteria or fungi are retained and nourished in the biofilm where the green stain is produced. So you've got blood pigments from the hemoglobin that are decomposed by the bacteria. And there's also predisposing factors that are related to a lack of personal oral care, the presence of means of retention of dental biofilm, as well as retained food debris. So from a clinical approach, you don't want to scale that area because often an area of demineralized structure underlines the tooth surface once you remove the stains and soft deposits. So you ask the patient to remove the soft deposits during dental biofilm control lessons or your oral hygiene instructions. And you want to initiate a daily fluoride remineralization program. Now, there are other green stains. So in addition to the clinical entity of the entire green stain that we just talked about, dental biofilm and acquired pellicle may become stained a green color by a variety of substances. So a differential distinction may be determined by questioning the patient or from items in the medical dental history. But green discoloration may also result from chlorophyll preparations for bad breath, metallic dusts of industry, and certain drugs. For example, smoking marijuana. That stain is going to be more green versus brown for regular tobacco. So this is an example of green stain, and don't you just want to take some pumice and polish that off? Again, you don't do that because oftentimes there's demineralized tooth structure underneath that. So now we have black line stain, and that's a highly retentive black or dark brown calculus-like stain that forms along the gingival third near the gingival margin. And this can occur on primary or permanent dentition. Other names for black line stain are pigmented dental biofilm brown stain and black stain. The clinical feature, it's a continuous or interrupted fine line. It's about 1 millimeter wide on average with no appreciable thickness. And it may be a wider band or even occupy the entire gingival third in severe cases, but that is very rare. It follows the contour of the gingival margin about 1 millimeter from the margin. So you usually have a little bit of space between the black line stain and the gingiva. It's usually separated again by the gingival margin where there is tooth structure appearing. It appears black at the bases of pits and fissures. There are heavy deposits that are slightly elevated from the tooth surface that may be detected by gentle application of the Explorer if it's really thick. But black line stain has been compared to a calculus-like deposit because it is tenacious and difficult to remove. The gingiva usually is firm with little or no tendency of bleeding. The teeth are frequently clean and shiny with a tendency to a lower incidence of dental caries. So this is what black line stain can look like. It can be this thick. Most times it's just a little bit thinner than this. It's on the facial and lingual surfaces and follows the contour of the margin of the proximal surface. It's rarely on the facial surface of the maxillary anterior teeth though. Most frequently it's on the lingual and proximal surfaces of the maxillary posterior teeth. For the composition, black line stain, like calculus, is composed of microorganisms that are embedded in the intermicrobial substances. The microorganisms are primarily gram-positive rods with a smaller percentage of cocci. So they are the gram-positive aerobic bacteria that's found with healthy mouths. The composition of black line stain is different from the composition of supragingival calculus, which is cocci predominant. So the attachment of the to the tooth of black line stain is by pellicle-like structure. Mineralization of black line stain is similar to the formation of calculus. For the occurrence, this can occur in all ages, more commonly in childhood, more commonly in female patients, and frequently found in clean mouths. So the gingiva is pretty healthy. The recurrence black line stain tends to form again despite what the personal care is. And the quantity may be less when the biofilm control procedures are really meticulous. So predisposing factors, possible iron deficiency, but there really is no definitive etiology. And then we've got our tobacco stain. It can be light brown to dark, leathery brown, or black. The shape, it can be diffuse staining of the biofilm. It can be a narrow band that follows the contour gingival crest slightly above the crest, so similar to black line stain. It can be wide, firm, tar-like band that covers the cervical third and extends to the central third of the crown. It can be incorporated into calculus deposit, and there can be heavy deposits, particularly with smokeless tobacco being used. The distribution is generally on the cervical third, primarily on the lingual surfaces, and It can be on any surface though, including the pits and fissures. Now the composition is tar and products of combustion. The brown pigment can also be incorporated from smokeless tobacco. Predisposing factors: smoking or chewing tobacco, or the use of hookah to inhale tobacco. The quantity of the stain is not necessarily proportional to the amount of tobacco used. Some people are more prone to getting stain, and they just might be, they smoke one cigarette a week and they can have heavy stain, versus a pipe smoker that smokes every day has very little stain. But personal oral care procedures can increase deposit occurrence if they're not meticulous with their oral hygiene. The extent of dental biofilm and calculus available then increases, so they're just going to develop more. For brown stains, the brown pellicle, the acquired pellicle is smooth and structureless, as you know, and it recurs readily after removal within seconds. So the pellicle can take on stains of various colors that result from chemical alteration of the pellicle. One of the main stains that can occur is stannous fluoride stain. And that is a light brown, sometimes yellowish stain that forms on the teeth in the pellicle after repeated use of some stannous fluoride products. Brown stain results from the formation of stannous sulfide or brown tin oxide from the reaction of the tin ion in the fluoride compounds. Now, a lot of our dentifrices have gone to stannous fluoride because it's a wonderful product. It's bacteriostatic. It helps desensitize. It's just a good overall fluoride, except for the staining. So there are formulations within the toothpaste to help minimize that. Other forms or sources of brown stains, aside from the stannous, can be pigmented foods. You've got your coffee, tea, soy sauce, those type of things that the pellicle picks up the stain from. And you have anti-biofilm agents, chlorhexidine gluconate, which is a prescription that the patient rinses with, notorious for tenacious brown stain, as well as alexidine, which are used in mouthwashes for tartar control. But you have brownish stains on the tooth surface that can result usually, and they're more pronounced, on the proximal or other surfaces that are less accessible to routine biofilm procedures, which means the brushing and the flossing isn't giving the friction that's needed to keep the stains at bay. So the stains also tend to form more rapidly on exposed roots than on enamel, because think about it, if the root surface is a little more rough than the enamel portion of the tooth. Clinical implications: again, you want to avoid the use of antimicrobials if there are enamel defects or porous restorations or margins that are present, especially the composite restorations in the anterior area. There's also something called betel leaf. And betel leaf chewing is common among people of all ages. In certain cultures, generally the Eastern countries, betel carries inhibiting effect. The discoloration is imparted to the tooth. That's a dark mahogany brown and sometimes almost black, and it becomes thick and hard and becomes very tenacious, and it can become partly impregnated into the tooth. Microscopically, the black deposit consists of microorganisms and mineralized material with a laminated pattern characteristic of subgingival calculus, and it can be removed by gentle scaling. Another type of stain is swimmer's stain, and that's frequently from frequent exposure to pools disinfected with chlorine or bromine that can cause a yellowish or dark brown stain on the facial surfaces of the maxillary and mandibular teeth. Another type of stain are the orange and red stains. And they are just as it sounds. Orange and red stains usually appear on the cervical third. The distribution, it's more frequently on the anterior teeth than posterior teeth. The occurrence is orange is more prevalent than the red. The etiology, again, is chromogenic bacteria. Certain bacteria like to pick up stains. And this is a yellow stain, right? It's very generalized. We also have metallic stains, and those are from metal-containing dust of the industry. Clinical appearance, it can be copper or brass are going to give you the green or bluish green. Iron is going to be a brown to greenish brown. Nickel is going to be green. Cadmium is going to be yellow or golden brown. So you've got a lot of different metal dusts that can create discoloration. The distribution of a tooth surface, primarily on the anterior teeth. Again, think about the patient inhaling this dust. The cervical third is more commonly affected. And the manner of formation, so the industrial worker inhales the dust through the mouth, bringing the metallic substance in contact with the teeth. The metal imparts the color to the biofilm, and occasionally the stain may penetrate the tooth surface and become exogenous intrinsic stain. So for prevention, the workers should be advised to wear a face mask while they are working, and metallic substances are also can be found in certain drugs. So the clinical appearance of the teeth can be, for example, iron. If they're using chewable vitamins with iron, can be black, iron sulfide, or brown. Manganese from potassium can appear black. You can have this all over the teeth, but the drug enters the biofilm, okay, and imparts the color to the biofilm. And the pigment from the drug may attach directly to the tooth enamel. So again, if the patient is using certain medications, you want them to be drinking through a straw, or if it's a tablet or capsule, you want them to just be using their posterior teeth with those. Now, occasionally, there are endogenous intrinsic stains, and that can result from a pulpless or traumatized tooth. The tooth becomes very dark, purplish, black, rainbow in color. It can occur with disturbances in tooth development, drug-induced stains or discolorations, and from other causes, and we're going to get into each of those. So for the pulpless or traumatized teeth, not all pulpless teeth discolor. With the improvement of endodontic procedures or root canal therapy, that has contributed also to the prevention of many of the discolorations formerly associated with that cause. But traumatized teeth that may not have been treated endodontically often discolor. The clinical appearance, there's a wide range of colors. The stains may be light yellow, brown, slate gray, reddish brown, dark brown, bluish black, or black, and others can have an orange or a greenish tinge to them. The etiology, though, for the intrinsic stain is blood or other pulpal tissue elements that may be available for breakdown as a result of hemorrhages within the pulp chamber, the root canal treatment, or necrosis of the decomposition of the pulp tissue. But pigments from the decomposed hemoglobin and pulp tissue penetrate and discolor the dentinal tubules. Stains can also be incorporated within the tooth structure that may be related to a period of tooth development. Defective tooth development may result from factors of genetic abnormality or environmental influences during tooth development. This can be hereditary, amelogenesis imperfecta. The enamel is partially or completely missing because of a generalized disturbance of the ameloblasts, and the teeth are yellowish brown to gray brown. There's also something called dentinogenesis imperfecta, or opalescent dentin. And the dentin is abnormal as a result in the disturbances of odontoblastic layer during the tooth development. The teeth appear translucent or opalescent and vary in color from gray to bluish brown. There's also enamel hypoplasia, and that is can be generalized or localized. Generalized hypoplasia is a chronologic hypoplasia resulting from ameloblastic disturbances of short duration. All right, the teeth erupt with white spots or with pits. Over a long period, the white spots may become discolored from food or pigments and develop stains. Then there's also local hypoplasia, which affects a single tooth. And that can be an individual white spot caused by trauma to a primary tooth that interferes with the development of the permanent tooth, or something called a Turner's tooth, which is a white spot that may become stained and generalized hypoplastic. Now, a Turner's tooth is an example of a local hypoplasia of tooth development. Then there's dental fluorosis, and we'll be getting into this more with the fluoride chapter, but this was originally called brown stain. And then later, a Dr. Frederick McKay, you're going to need to know that for the fluoride chapter, studied the condition and described it in dental literature and named it mottled enamel. And the etiology is enamel hypomineralization resulting from ingestion of excessive fluoride ion from any source during the period of mineralization. The enamel alterations are a result of toxic damage to the ameloblasts. So when the teeth erupt, they have white spots or areas that may later become discolored from pigments, or discolored areas that appear light to dark brown. In severe cases of excess fluoride during development, the teeth produce cracks or pitting, and the discoloration concentrates in those cracks and pits. And this condition and appearance has led to the name of mottled enamel. Now, Dean, another doctor, provided the original definitions of the 5 grades of fluorosis, and that's going to be in chapter 23. We've got 23-2 in chapter 23, and they range from questionable, which are just a few white flecks or spots, to severe, which are the marked brown staining and pitting, which is indicative of mottled enamel. So we'll be getting into that in another chapter as well. But so there are grades of dental fluorosis. The more specific classifications have been developed for clinical and research purposes, and we'll be talking about that in fluoride. So we've got drug-induced stains and discolorations as well. Tetracycline being one of the common ones that we used to see a lot. Tetracycline antibiotics and their derivatives were used widely for combating many types of infections, and they have an affinity for mineralized tissue. They are absorbed in the bones and the teeth, and they can be transferred through the placenta and enter the fetal circulation. The discoloration of the teeth of the child can result when the drug is administered to the mother during the 3rd trimester of pregnancy, or to a child in infancy and early childhood. The teeth color may be light green to dark yellow or gray-brown, with or without banding, and that banding almost looks like it's a rainbow effect with the banding. The discoloration depends on the dosage, the length of time the drug was used, and the type of tetracycline. After eruption, the teeth may fluoresce under ultraviolet lights, but that property is lost with age and exposure. Discoloration may be generalized or limited to a specific part of the individual's teeth that were affected during the development when the antibiotic was administered. The patient's medical history at the age may reveal the illness for which the antibiotic was prescribed. Then you have Cipro and minocycline that are used today, and they can result in a greenish discoloration of the teeth, also the bone, and sometimes this can be reflected through the gingival tissue. And there are other systemic causes for tooth discoloration, and there are several types of discolorations that can be resulting from bloodborne pigments. So you've got pigments circulating in the blood that is transmitted to the dentin from the capillaries of the pulp. So, for example, prolonged jaundice early in life can impart a yellow or greenish discoloration to the teeth. Erythroblastosis fetalis, that's the RH incompatibility, may leave teeth green, brown, or have a blue hue on the teeth. We have exogenous intrinsic stain, and when the intrinsic stain comes from an outside source, not from within the tooth, the stain is called exogenous, originating from outside the tooth. Intrinsic becomes part of the tooth. Extrinsic stains such as tobacco, tea, coffee, wine, green stains can become intrinsic. So restorative materials can also cause stains. Tooth-colored restorations may become stained from the various extrinsic staining substances as well. So one of the restorative materials that can create an exogenous intrinsic stain is the silver amalgam. And that can impart a gray or a black discoloration to the tooth surface. Metallic ions migrate from the amalgam restoration into the enamel and the dentin. Then you have silver, tin, and mercury ions eventually contact the debris at the junction of the tooth and the restoration, and they form sulfides, which are products of corrosion. Then you've got, so that's the silver amalgam. You also have copper amalgam, and that's used primarily to fill primary dentition and may impart a bluish green color. Root canal therapy, endodontic therapy uses silver nitrate, or they used to, and that can give a bluish black tinge. Volatile oils can give a yellowish brown. Strong iodine can give a brown stain. So it depends on what the root canal therapy treatment is and what root canal sealer they're using. This is a picture of intrinsic stain, most likely exogenous according to the book, from an outside source such as tobacco or food. And look at where it is. It is on enamel, but also on the root surface. And you can see, especially the maxillary teeth, the cervical erosion that allow the yellowish color of the underlying dentin to come through. So you don't want to be doing heavy scaling in those areas. So there's also exogenous intrinsic stains that can stain in the dentin, and that's discoloration resulting from carious lesions, might be an example of that, or arrested decay or secondary dentin can present as a very dark stain. Other causes for exogenous intrinsic stains can be a low pH. The degree and type of discoloration are influenced both by low pH and food color rather than dietary pigment alone. Enamel erosion is the loss of hard tooth tissue by chemical means such as acetic acids, including carbonated drinks, and eating disorders such as bulimia, where the acid from the stomach is coming up, and acid reflux. It results in a thinner enamel, allowing the yellow color of the underlying dentin to show through. There's age-dependent erosion, and that's not supported in the literature, but it's considered to be a pathological process because the teeth are wearing down and the underlying dentin in the tooth is showing through. Whitening products are ineffective as well as contraindicated for erosion. Attrition of occlusal surfaces can result in loss of enamel, allowing the yellow outline of the dentin to show through again. So you have patients that have different kinds of stain. You want to be the detective and try and determine what the type of stain is, which stains, the location, the color, the type, and extent is what you want to document. And you're going to document that in the treatment notes. And again, you also want to teach the patient what the stains are from. A lot of times, for example, black line stain, there's very little calculus, but you're spending most of the appointment time trying to scale off that black line stain because it doesn't polish off and you don't want to destroy the enamel in the process. So that requires a lot of fastidious scaling. So you want to obviously teach the patient about the type of stains they have, and if it bothers them, especially what they can possibly do to avoid having those stains. And that, my friends, is chapter 22.